No. All right.
All right, it is 8 o'clock, so we'll get started with ocular pathology rounds today. My name is Megan. I'm one of the staff pathologists, and I'll start us off with a couple cases. There we go. All right. So the first case is a bit of an unusual species. This is a common carp, 25 years old. So a nice, well cared for carp. This patient had severe exophthalmos of the left eye with visible opacities in the eye, consistent with white blood cells, blood, and/or soft tissue. They did an ocular ultrasound briefly before nucleation, and the globe appears infiltrated with soft tissue or white blood cells. The appearance in the anterior chamber is heterogeneous. Structures such as the lens cannot be easily identified. Suspect chronic inflammation, eye is not visual, and they took it out. The right eye also had a bit of a mild corneal abrasion, but was not the eye of maximal interest here. So their assessment by ultrasound is pretty much our assessment by gross view. We do have a cornea up here. You can kind of make it out. So here's one side of the limbus, here's the other side of the limbus. And the eye is essentially bulging with all of this soft tissue type material, sort of a semi-firm material, which kind of ranges from brown to like a white tan to like an orange yellow. You can just make out the choroid in this case. So this is part of our choroid here. And then the iris here, which is kind of cute little iris. But the iris is maybe displaced or distorted on the other side. It's hard to make out the uvea elsewhere. Fish do have fat in their suprachoroidal space normally, so a lot of this probably is fat, but it looks abnormal. Too thick, it's differently thick on one side versus the other. So there's all sorts of sort of distortions going on in this globe, and indeed, we can't really easily make out a lens, and it's full of basically soft tissue type stuff, just like they said by ultrasound. So let's take a look at the histology. Full screen all the way. All right. We could try to do a subgross.
Ooh.
Yes, so heterogeneous. Here's the lens. Look at it. There it is. We do have a cornea. It's pretty thin and anteriorly bulging. And we have a bunch of like pink to purple tissue, so cells, blood, all sorts of chaos going on here. And then in particular, an area of interest is sitting right here in kind of like vitreal space or so, with all of this purple where there are cells. So let's take a closer look at all of this. We're going to start by going right to the area of interest rather than doing our usual front to back, but usually we go front to back. For rounds purposes only, will not keep you in suspense. So here's that purpley tissue. The cornea is to our right. The optic nerve would be to our left. We drop in on this stuff. And if we go to a field that I like slightly better, oh, please. We're going to like this area a little bit better. We have a neoplastic population. Drop in one more, I think. And these neoplastic cells are sort of cuboidal to columnar. Oftentimes they're sort of carrot-shaped or so, with sort of a tapered base and a more rounded apex. They form essentially tubules to maybe rosettes, like maybe some of these could be like semi-convincing rosettes. And they often form these kind of like cystic or dilated areas that have a little bit of blood or protein in them. And basically these guys are looking kind of like primitive neuroectoderm. So this is sort of a form of peanut. And then this one has an added bonus if we drive right over to the edge of it. Wait for it. This is decent. So there's this area that the tumor kind of blends into, and we can see these guys, which are looking like ganglion cells or neurons, and we can see all these little tiny nuclei, which are looking like glial cells. So this is like, here's more like kind of ganglion cells. So this is like really disorganized neural glial tissue. And at least in terms of like how expansive this is and how disorganized it is, we wouldn't expect to see something like this normally at this site in the eye. So this is part of the tumor. So we have sort of a primitive neuroectoderm population and a disorganized neuroglial population. And together that gives us our diagnosis in this case, which is teratoid medulloepithelioma, kind of a fun diagnosis. So basically, medulloepithelioma is that primitive neuroectoderm part, and then the fact that it's also making this kind of disorganized neuroglial stuff, kind of showing maybe like a pluripotent sort of a presentation. We add teratoid up top. And this entity has been published in fish before, and also one eel, I believe. But basically, it's a thing that sometimes happens. It has presented either unilaterally or sometimes bilaterally in these cases. It's unclear whether it's like de novo tumors on both sides or if it's extending along the optic nerves. But potentially, this should be sort of an invasive tumor, and watching the other eye would be reasonable. But yeah, this is an interesting entity and we don't get it that often. So that's our main event tumor. And then we kind of have some cleanup or some additional things for this fish. So if we walk up here to the lens, we do still have a sort of normal looking nucleus, but the lens capsule is separated from the lens and the cortical fibers are just sort of fragmented. So some of this could be artifact, but the way that it's all sort of embedded amidst all this tissue suggests that there's probably some degree of like true in vivo like rupture and fragmentation of the lens fibers.
Just a second, Megan.
Oh, go ahead.
When you were talking, the microphone wasn't working when you mentioned the name of the tumor. Can you say it again? Teratoid
medulloepithelioma. We'll also have it in writing at the end, if you need a spelling, for example. So the lens is fragmented, and that suggests some degree of trauma. We do also have some significant corneal disease with ulceration and keratitis, which is probably just exposure in this case. We're not going to dwell on that. Let's see, we just saw it. Here we go. There are rarely fragments of what is recognizable neurosensory retina, but otherwise we don't see much of it. This is like pretty much the one fragment that exists that looks like retina still. So it implies retinal detachment and tear. We also have quite a bit of hemorrhage and inflammation inside this eye. So long story short, it's likely that this eye experienced trauma at some point in addition to the tumor. So, unclear if it was like trauma after the eye was already blind or trauma and tumor or like, what relationship these things may have had. But interestingly, there's histologic evidence of trauma accompanying this. And then the last thing that's kind of interesting in this case, well, actually, maybe not the last thing. We can walk briefly into the suprachoroidal space. This structure is really cute. So see this structure right here, kind of in the suprachoroidal fats. It's very richly vascular. This is actually normal. It's called the redi mirabilis, which I love that name. It sounds like miraculous. I don't know. Redi mirabilis or like the choroidal vascular reti is just a normal structure. But then also you can see that this suprachoroidal fat is inflamed, edematous. There's lots of pigmented macrophage centers about, so that's part of why it was so thickened at gross. And then the last thing that I'm going to show you. So over here, especially kind of along the sclera, maybe sort of in the suprachoroidal space on this side, maybe sort of in the choroid up here, we have a lot of these small round cells. Just lots and lots of pretty monotypic looking round cells with small nuclei and a condensed chromatin pattern. They don't look particularly like pleomorphic or they don't look particularly pleomorphic or like angry, but they are sort of packed into blood vessels frequently. Maybe that area isn't convincing. Hang on, I'll show you. Seems reasonable. So there's a lot of them circulating in the blood, apparently, and or maybe draining through lymphatics. And there's a pretty sort of like forming sheet-like monotypic population. So this we refer to as basically like a monotypic lymphoproliferative population. It could just be reactive still, but we suggested that they check this fish's blood work to see if there's anything unusual circulating in the blood in general and not just responding to this one trouble spot. Because maybe we could think about some sort of like neoplastic lymphoproliferative population. But that was sort of like a differential on this case. And the main thing of interest was the tumor. So now that we've been through all the extras in this fisheye, we'll head back to our gross image and then show you the main diagnosis. That's it. That's all I had to say about the carp. Does anyone have any questions or comments? A lot of stuff going on. Apparently we had the other microphone as our main microphone, so hopefully the sound is better.
It wasn't. It was
Oh, it wasn't?
kind of combined
Oh.
when I was listening, so it was getting a little bit
It
more
was sort of
overall.
overlapping. Okay.
But I think if you hear, I think everything went down when I sneezed.
Oh.
If you went to this one and not that one. We're back.
With that, we did the second microphone now is to try and make it better, but anyway, all right. Sneeze recalibration. Okay. There's nothing else about the carp. We'll go to the next case. This one's a little bit more of a classic. I figured we have a kind of rare and then maybe more classic. All right. So no, all right. This is a 4-year-old neutered male Belgian. Sorry, a Belgian gelding, I should say. 4-year-old Belgian gelding. So a horse. The right eye appeared phasical with diffuse corneal fibrosis and keratitis, marked mucoid discharge. The lower eyelid palpated firm. Advanced imaging was not performed. This was a rescue horse from Kilken's. So they rescued this horse and it's had this bad eye. Retrobulbar mass was found in surgery and they were unable to obtain clean margins, unfortunately. The other eye, interestingly, so the left eye, had a third eyelid mass consistent with squamous cell carcinoma, but the biopsy was currently pending at Antec when we got this eye. All right.
Source of bilateral.
Squam, potentially.
You repeat
Spoilers. It's a spoiler. I'm just gonna keep going. Sort of. You may already be on the same wavelength anyway. All right. So we have our gross view of the eye. The optic nerve head is actually right here. So this is the dorsal eye, presumably, and then the ventral eye is a little bit like foreshortened. So we do have kind of like a small, maybe shrunken, maybe slightly wrinkled eye, which is part of phasis. But mostly the distortion is happening because of this giant tumor, which I should probably point out first. But so it's here in the uvea, so it's in the iris, it's in the choroids, in the ciliary body. You can see more of it deeper in the hemisphere of globe here, sort of bulging forward and sort of displacing the retina on top of it. The retina looking like a wedding veil, essentially. And then you have similar neoplastic tissue in the episclera / orbital tissue outside the globe as well. You can see that this tissue is sort of white tan, and you can see lobulations to it even from gross view. The lens is slightly displaced by all of this, and the vitreous is kind of yellow tinged, which is pretty common in horses with any sort of like inflammation inside the eye or anything weird going on in there. All right. Let's go to the histology. See if we can get a decent subgross going. Yeah, that one never works. We're gonna do this one. So what? We have a lens. We do. Yes, we do. There's a lens. Just like the carp. All right. So we have up here in the cornea, you have the iris down here to orient you and little corporate nigra here, very cute. But we have the cornea up here, and there's all of this purple stuff that's eating up the superficial to mid, sometimes even deep corneal stroma. So really invasive. We have one tip of iris on this side, and then the rest of it's just being eaten by this tumor. We can see the similar tumor diving through the sclera. We can see it out here in the episclera. And we can see it all the way back down here, kind of close to where the optic nerve is. So here's the optic nerve, here's tumor. All right, let's take a closer look. I think this will make it backward from what we just had. Possibly. Yes, it will. Okay, hang on. I can make it the same orientation as we had before. There we go. All right. So this neoplasm, you can see from magnification, is forming these lovely, lovely for a pathologist maybe, multifocal to coalescing lobules. And a lot of these purple lobules have this bright pink in the middle, which is very suggestive. Here it is in the cornea, and then we kind of give way after this tumor to more normal non-neoplastic epithelium of the cornea. And then we can see it down here invading the uvea. So it's sort of in the iris base, and poor little iris is just sort of flapping off the end, and then really severely distorting the ciliary body. And this pink in this tumor is keratin. So it's making a lot of keratin, and you can see it floating around everywhere. There's even like a piece of keratin just out here. And some of these areas are basically just like necrotic tissue with like seeds of keratin multifocally. So a really keratin happy tumor. But a pretty classic diagnosis. So we have these epithelial lobules. The more basally or outer oriented cells have somewhat less amounts of cytoplasm. That's a little bit more basophilic. And then as you progress towards the center of a lot of these lobules, the cells have more abundant and sort of more glassy or eosinophilic cytoplasm. And then many lobules in the middle, we progress to these lamellated, compact layers of keratin, which oftentimes when they form these cute little nests in the middle of these lobules, they are referred to as keratin pearls. So we have an epithelial neoplasm that has a squamous differentiation. So this is a squamous cell carcinoma. A pretty classic diagnosis. And just again, showing off the extent, we lose the uvea a little bit, unfortunately, artifactually in this section, but here it is in the sclera, just to show you its invasiveness. Here it is back in the choroid. Barely any uveal tissue left here. It's pretty much all this tumor. And here it is extending as far back as the orbital tissue, kind of next to the optic nerve. Same tumor. So this is a really invasive neoplasm. I can show you the eyelids, and it was the same sort of thing. Why don't I do that?
Go up, yeah, just up there one lower, and then it looks
Yes.
like you're treating the vasculature around the optic nerve here.
Yes, there was suspicion for vascular invasion in this case. I
Yeah.
can't remember if I ever found one that was like super convincing, but
See there should be
Mm-hmm.
large vessels in there, and it's at the region of the, well, I mean, the left normal vessels,
Yeah.
left, yep, and it's at the region of the short posterior ciliary artery branches.
yeah, and the way it's sort of forming like a donut
Mhm.
here. It's often hard to make out the endothelium around it, but yes,
Yeah, it's more based on location and
yeah,
the
exactly.
focal round nature of it than the identifying it as a vessel itself.
Exactly. Yes, I ended up putting suspected vascular invasion because I'm a bit of a weenie, but did warn about vascular invasion in this case. All right. Briefly, there's tumor already. Let me orient you though. Here's the haired skin. And here we are with neoplasm. Oh, here, like for example, I don't even know why I put suspected if it's here. That's vascular invasion.
This is the other eye?
This is the eyelid from the same.
Oh, the same, okay.
Yeah, that's vascular invasion.
Yeah.
Anyway,
Doesn't matter if it was anywhere else, it's there.
yeah, exactly. That's a good one. Woof. So this is the haired skin of the eyelid, and we do have this really invasive neoplasm all throughout the subcutis and kind of periocular tissue diving in deeper and maybe in the conjunctiva. So it's a really, really invasive neoplasm.
Any solar change here?
Yes, good question. So Gillian asked if there is any solar change, and if I recall correctly, I did not see any, though I did look all over for it. So this is a Belgian horse. And we have a history of presumed bilateral squamous cell carcinoma. Here, let me drop on something more interesting before we start talking about this. All right. So the left, let's see what the guys. Okay, the left third eyelid also had squamous cell carcinoma. This eye has this really invasive squamous cell carcinoma that involves the ocular surface. So in terms of why this was bilateral, one potential thought is solar-induced change. So there's a couple of horse breeds. So Belgians, Halfwingers, Percherons are kind of in that list. But there's a bunch of other ones that have been added since then, like Conmera ponies and some other breeds or types of horses. And they have this prevalence of a certain mutation, so DDB2 mutation, which makes them more prone to solar-induced injury. Basically, that mutation is like one in a repair mechanism of the DNA. associated with UV radiation. So they are less able to repair their DNA after UV radiation. They're more prone to solar-induced neoplasia, long story short. So definitely put in the comment about how I would kind of suspect this horse may be one with a mutation, and that might explain why this horse got squamous cell carcinoma in both eyes. Horses, in terms of solar-induced mutations, horses with lightly pigmented skin around the eyes, or animals with lightly pigmented skin around the eye in general, and then some exposed areas are kind of more prone. So ocular surface, especially lateral ocular surface, and third eyelid, especially leading edge of third eyelid, are particularly some exposed sites where you might get some solar-induced tumors. But there are certainly also other ways for squamous cell carcinoma to form. It's not always a solar-induced tumor. But that would be the suspicion in this case. Any questions or comments other than that? Just a particularly invasive, definitely vascular invasion. Just a particularly invasive and extensive squamous cell. Plus a good discussion, I thought, about the sun-induced stuff. All right, All right. Hi, my name is Kelsey Brown. I'm going to be doing the next two cases. My first one is pretty short and sweet. My second one is much longer, so hopefully that makes up for it. So this first case is going to be from a 4-year-old male castrated domestic short hair. We don't have a growth image, but the clinician was kind enough to send us a clinical image, which we appreciate. So I guess I should actually provide history. So this cat presented with a red and cloudy right eye, which is the eye we're kind of seeing here. It was described as mildly bucthomic with moderate chemosis. The anterior chamber was filled with fibrinous material and the iris was severely thickened. And the posterior segment cannot be visualized, which we can definitely see in this particular case. It is quite cloudy. There was no glaucoma documented, and this problem had been present for about 2 months. Also of note, this cat did have a mild fever. They reported an oral temperature of 104.7 degrees.
Is the how effective is tonometry in an eyeball like that?
That's a good question.
I don't know.
It'd be hard to tell, but
Yeah.
I'm thinking that they can have like an increased pressure because of something present, but then the uveitis can drop it. So sometimes we'll get artificially like normal pressure.
Yeah.
So we have to like contextualize it.
Yeah.
But I mean, with that specific, we'll see more of what's going on, but I mean, like that specific change.
That's one thing to think about with the uveitis. And so also tonometry is based mostly on the like elasticity of the cornea.
Right.
So yeah, exactly. The question is like if there's a really severe corneal edema, for example, or if there's like tumor inside the eye, or like really like large amounts of inflammation, or like the lens pressed against the cornea, like these things might change the elasticity of the cornea and affect your reading. But you know, there could be any number of things going on in this eye, and it's hard to tell. So
But we will find out.
we'll find out. Yeah, exactly.
Dr. Brennan.
And grossly, we described that the orbital tissue around the globe itself was extremely firm and thickened. So that could also be contributing to the bucthomic effects that we saw grossly and they saw clinically. We also described exudate flesh clots in the vitreous.
actually, you said he couldn't hear the background. Can you just summarize what was said about?
Yeah, so there's a question about how reliable tonometry is in cases like this. If there is, you know, any degree of corneal disease, can we believe that reading when they say there's no glaucoma, say, in a bucthomic eye? And I guess to summarize, the answer is it depends on what's happening.
Yeah.
All right, so that's
No,
not
it's
the
another
camera.
squamous cell.
Yeah, more squamous cell. Need a theme. Let's see. Okay. So I guess I'll try to do a subgross. No, I'm quite bad at this, but maybe I'll learn one day.
You had your practice.
Yeah, I always avoided doing this though. It's like really shaky hands. Also, it's not really focusing.
Use fine focus.
Do I really?
Well, see, it goes to show how not often I do this. Here we go. All right. Yeah, here we go. All right. It's still pretty cloudy. But doing my best. Okay. So corneas up top, posterior segment is going to be at the bottom. And already from this subgross view, cornea itself is relatively unremarkable. There's this eosinophilic kind of proteinaceous material in the anterior chamber, these little cells. Looking at the anterior uveal tract, there are these little clusters of purple, so it's a little more cellular here. And as we move back, there's a similar kind of proteinaceous material in the vitreous as well. This is the retina. We'll go closer to see that, but it is detached. It's kind of plastered against the posterior lens capsule. And then as we go all the way back, in the kind of orbital adipose here, peripapillary connective tissue kind of sneaking maybe into the sclera and choroid, there is this cellular infiltrate. There we go. All right. So now cornea is going to be on right, posterior segment will be to the left. And the only thing I'll point out with the cornea was there was a little bit of an ulcer, which they did describe clinically as well. That's really all I have to say about cornea. Otherwise, we'll focus kind of on the cellular infiltrate here. And
So just about the cornea, just to point
Oh, yeah.
out how unremarkable it looks histologically compared to that clinical image, right? So just to, that highlights how sometimes we underestimate or we are not able to diagnose corneal edema or
Yeah,
changes
which-
like that.
a little bit pallor, so I believe it. And looking at the clinical photo, obviously there was edema, but agreed, it can be more subtle histologically compared to what they're seeing clinically.
Sorry to interrupt.
Oh, no worries. No, it's a good point. So yes, we have the cellular infiltrate in the anterior chamber. As we get closer to look more at this uveal tract, not only are these kind of these very purple cellular infiltrates, but the rest of the stroma itself also looks quite busy. And this also corresponds to a pretty dense cellular infiltrate. It's really just the more of what we're seeing so far is there's just cells really in all of the layers of this eye. And as we go back, there's more in the orbital adipose, it's in the choroid, so there's a panuveitis, some cells floating in the vitreous. Now let's actually look at them. All right. So in our anterior chamber, excuse me, most of these cells are going to be macrophages, and some of them are multinucleated. Maybe this guy's 3 nuclei. In addition to that, there are some neutrophils also floating around. What maybe has caught your eye is that within a lot of these macrophages, there are organisms, all of these little guys. And I can even try to go one closer. So within the cytoplasm of these macrophages are these round to ovoid, pretty small little organisms, which are fungal yeast. They are surrounded by this little thick clear space, which is just a shrinkage artifact. It's not a true capsule. And I can kind of scroll around just to show how many there are. They're virtually in all of the macrophages.
Target-rich environment. Drop anywhere.
Yeah, right. This is a nice, easy one. There's very little searching to be done. Here we are in the iris stroma. All of these macrophages. Honestly, yes, want me to keep showing you. It's just going to be more organisms as we go around. Yeah, scooch back here, maybe. Drop down into the orbital tissues.
That was even better if I remember correctly.
Yeah,
Oh, wow.
that's where I started. And here they all are. All of these macrophages have fungal yeast within them. So this is a very florid example of histoplasmosis in a cat.
Do you have a 16 on this one?
We do.
Just for the.
Yeah, of course. I can stop here even. Honestly, it's just really within every single layer. So we'll stop and point these guys out. There they all are. And they are restricted to the macrophages. We're not seeing them in any other cell type or extracellularly. So that helps corroborate the fact that this is histoplasmosis. This cat is also from Ohio, which is a hotbed for histoplasma. So everything is quite fitting in this case. So ocular histoplasmosis is typically a manifestation of systemic disease. So these cats will typically inhale the microconidia and then it will disseminate to various organs, the eye being one of the classic ones we can see it in. typically is not quite this florid, at least in my experience. I've had to go on quite the bug hunt in the past, so this is a nice one, I guess, for me, not for the cat itself.
This is this is a good point because this is relatively atypical.
Yeah.
I've looked to like almost all of our cases at some point
Mhm.
because I was doing a retrospective study,
Mhm.
and most of the cases without a GMS, it was really hard to confirm. This was one of the most obvious ones I've seen on HME. Like,
Yes.
this is beautiful.
Yes, so easy to provide an answer, yes. In this case, this cat did have a fever, and I didn't mention that in the other eye, they mentioned a partial bolus retinal detachment, and there were two distinct discolored zones concerning for chorioretinal granulomas, which kind of helps corroborate that probably this cat does have systemic histoplasmosis, unfortunately.
I feel like normally they're systemically normal.
Yeah.
So this cat is particularly unusual.
Yeah,
Yeah.
I do kind of wonder, yeah,
I'm
there's something
not
else going
surprised
on.
clinical with that number of organs,
Mhm.
Yeah.
some sort of immune compromise.
Yeah,
So Maria was asking if there was any cause for systemic immune suppression.
not in the provided history for us, at least. Yeah.
That's an interesting point also because going back to that a project I've mentioned, we've not I would say the minority of our cases had any history or any well that it came in a history of any reasons for immune suppression.
Mhm.
So it could be just that they didn't inform us, but it didn't seem to be you know, an obvious thing, or steroids as she mentioned here.
And honestly, that's kind of the major finding here. Really just, yeah, raging ocular histoplasmosis.
It is a major finding though.
Yeah, right. Okay. So let's do that. So, yeah, severe granulomatous with lymphoplasmacytic areas throughout the ocular and extraocular tissues. And yeah, morphology, patient location, the distribution of these fungal yeast most consistent with histoplasma encapsulatum. So kind of a short and simple one to start. Are there any questions or comments on this one before I move on?
Were the filtration angles plugged up?
That's a good question. Let's speak. Question was, were the filtration angles plugged up? And I would say, it sure looks like it. Essentially here, over here, there's a little bit of an artifactual cleft, so a little bit harder to gauge, but
Sounds like
make up a little bit of these the pectinal ligaments here, trabecular meshwork.
Yeah, because it brings up the question of, you know, if you have a chorioretinitis, is there an increase or decrease in intraocular pressure, but what else is going on? So you could have a net increase because of.
Yeah, it's true.
Cool, thank you.
All right. Next one. I actually have a group image for this one. So this one's a little bit complicated. There's a lot of procedures that was performed on this particular globe, but I'll try to keep it concise if I can. So this is a globe from a 13-year-old female spayed Havanese who had many procedures done. So over the past year, this eye had cataract surgery. You can see a little intraocular lens in place right here. It had endolaser performed twice, so a cyclophotocoagulation for glaucoma. It also had 2 Ahmed valve or gonial valves placed, which I'll point out the structures of that once I finish with the history. They described forward displacement of the intraocular lens. A gentamicin ablation was performed at one point as well. And then they described that the eye produced granulation intraocularly, causing the cornea to protrude, which you can see up here. They said no to glaucoma, and then other general medical conditions given to us were this dog had diabetes mellitus, Cushing's disease, and a heart murmur. Poor dog's got a lot going on. All right, so there's a lot of things to point out here in this gross heavy section. I already pointed out there is an intraocular lens in place consistent with cataract surgery. We do have evidence of our Ahmed valve in this picture. So Ahmed valve is typically a plate that is going to sit kind of in the subconjunctival or episcleral region, and that's where this plate formerly was. We take it out because it does not process very well. The histology lab would be angry if we left it in. That plate then connects to this little tube. So you can see the tube protruding out here. that is going to go into the anterior chamber. So the end of the tube is actually visible right here. And it acts almost like a little shunt when the intraocular pressure reaches a certain threshold. So we have that. Other things that we can see, indeed, the cornea is protruding anteriorly. It is extremely thickened, and there are these kind of cavitated areas of necrosis and hemorrhage.
This would be a cornea that you couldn't trust to not treat it.
Right.
I would not. I feel good about that.
Yeah.
I'll watch that one,
Yeah, right?
especially in knee props.
Yeah, yeah. The intraocular lens did seem to be anteriorly displaced. This globe is quite malformed, so sometimes it is hard to trust the placement of the lens, but in this case, it was broadly contacting the posterior cornea, which is not right. That should not be happening. Here is the anterior uvea. It's a little bit hard to make out the specific structures. The iris has been reduced to a nubbin, essentially, at this point, so extremely distorted. There's some kind of tan tissue along the posterior aspect of this intraocular lens. And then we have our retina right here, which is detached.
Can you point out that the deep corneal stroma actually is visible and looks relatively normal?
Like right here?
That one.
Yeah.
That sort of gelatinous.
Like the more opaque, like
Yeah,
colorless, opaque
yeah,
kind of band.
it's interesting. At least I can't remember what the histo looks like.
No, there's like a nice
Yeah.
zone of normal
Yeah.
stroma. So no, that's a good thing to point out. Thank you.
And it helps localize it in the corneal stroma, which, you
Yeah.
know, some people might interpret that as just an anterior uveal mass
Mhm.
expanding everything, but that's the
Mhm.
cornea.
All right. Might do this right this time. Oh my gosh. Okay. Wednesday. I'll get it all the steps right. Oh my gosh, this one's a really awkward angle on the slide, so I'll do my best. Okay. So here's our subgross of this globe. Really what's occupying the screen at this point is the cornea. This is the cornea. It is not correct. The deep aspect of the stroma, as Dr. Shaw pointed out, does look relatively normal-ish. And the rest of the stroma is disrupted by just this large area. There's kind of these areas of pallor. Here's that cavitation with necrosis and hemorrhage within it. So all this pink here is necrosis. As we move over this way, this was the site of the Ahmed valve plate, which we also call the bleb. And normally what we would see is kind of this fibrous capsule around it, which is what we're seeing here. There's maybe a little bit of a cellular infiltrate adjacent to where the tube is, but pretty mild. As we look into the eye itself, this is where that intraocular lens was sitting. As we pointed out grossly, the iris and ciliary body are pretty distorted at this point, or kind of just pressed up against the posterior aspect of the cornea. They're very shrunken, don't look quite normal. There's a little bit of lens capsule. I'll go closer to show that. It's all wrinkled up here. And there's this collagenous tissue, which we saw grossly. And the retina is detached. There's a mysterious blue dot, which we'll look at. And then our optic nerve, out of all the structures, is probably the most normal, which is great.
Do we know the timeline for the surgery?
They said within the last year,
Okay, good.
all of these procedures were performed.
Good enough.
Many things, yeah. It's an expensive eye, I'm sure. So it's kind of sad that it had to get taken out, but understandable in this case. Okay. So first I'll start by just showing the little blood from this Ahmed valve implant. There's not too much to show here, just that there is indeed a fibrous capsule around where that blood is in the episcleral space. That inflammation is mostly granulomatous. Interestingly, there are some eosinophils in here as well. There aren't eosinophils in any other structure in this eye, so I'm not quite sure the significance of it and why it's there. But there it is. And then showing that Ahmed valve right at the angle here is kind of the dorsomedial iridocorneal angle. There is this kind of refractile material. I'm gonna run my finger here to show it. So this is that gonial valve or Ahmed valve tube as it's entering into the anterior chamber. We kind of caught that in section. All right, so let's show the cornea. What's going on here, in addition to everything else going on. All right. So this corneal thickening is due to this very robust granulomatous inflammatory infiltrate. So all of these are macrophages. There are some multinucleated giant cells in here as well. And the reason it's so pale staining is because their cytoplasm is distended by all of these kind of teeny tiny, rather discrete vacuoles. So this is lipid. So we have lipid-laden macrophages. And in some areas, there is this kind of crystalline material that they're interspersed with. Sometimes it's within their cytoplasm. In some areas, that material is birefringent. I have to remember exactly where it is. There it is. Gotta focus first. There we go. Ooh.
A lot of stuff in there.
A lot of stuff. And then moving over to, there's these areas of necrosis and hemorrhage, and then kind of flanking these areas of necrosis somewhere, there's areas with neutrophils. But the majority of this infiltrate is this granulomatous or lipogranulomatous, if you will, inflammation. And then we can drop down to the deep corneal stroma where it is relatively normal. There is some vascularization, but I think we have a good reason for that. Otherwise, yeah, we can see the nice normal lamellar arrangement of the stromal collagen. All right, back out one. So here's the region of that intraocular lens. I can run my finger under and we can see kind of this refractile structure there. So we didn't catch it in section or didn't come off the slide, which is nice. Right behind that, we have our lens capsule. There it is. And there is a sharp discontinuity in the anterior lens capsule, which is what we expect to see with a dog that has undergone cataract surgery. Typically, we'll see this is our capsulotomy region from the anterior lens capsule. But the intraocular lens is no longer within the capsule itself, unfortunately, and the capsule is wrinkled up and it's embedded within this kind of collagenous tissue. And that collagenous or fibrovascular membrane does extend over the ciliary body, over the iris, causing this distortion. The iris is plastered up against the posterior cornea, causing broad anterior synechia. There's really not much of an anterior chamber to speak of anymore. There's the myolymphoplasmacytic anterior uveitis.
Contractly obliged.
Yes, as we must see. If it wasn't there, I would be confused. Within this kind of collagenous membrane that's going along the posterior aspect of the lens capsule, there are some little asteroid bodies embedded within here, which is a very cute finding. Sometimes our macrophages trying to gobble up those asteroid bodies. Not our most important finding here, but kind of a fun feature. And then here is our detached retina. Adjacent to that within the vitreous, there's some intraocular hemorrhage and some hemosiderin-laden macrophages. And then, as we see often with retinal detachment, there is an outer retinal atrophy. So we can still make out some ganglion cells, but there's really no inner or outer nuclear layer to speak of. And then the dot telling us to look over here. And in our central retina, we have severely thickened vessels. So this is formerly a retinal vessel, a little hard to make out the lumen at this point. And the vascular wall is thickened by more of these lipid-laden macrophages. There's kind of this eosinophilic, sometimes hyalinized material here, and sometimes mineral within the vascular walls. So these changes are consistent with atherosclerosis. And those are the major findings. I think I could talk about this globe for a very long time, but for the sake of time, I'll move to the diagnoses and chat about everything going on here. It's a lot of diagnoses. So these findings are consistent with the multiple procedures that were performed. Of note, that corneal thickening corresponded to xanthogranulomatous keratitis, which xanthogranulomatous intraocular inflammation we do often associate with serum lipid derangements. So commonly we'll see the mini schnauzer, we'll see it with dogs with diabetes mellitus. There was a somewhat recent case series that came out of Coplow describing these surface ocular xanthogranulomas, and a large subset of them didn't have any serum lipid derangements, which is interesting. In this particular case, this is a dog that has diabetes mellitus and hyperhidrocorticism and evidence of atherosclerosis. So I suspect some sort of serum lipid derangement was in play here for this particular case. And then other things, we did confirm there was an anterior IOL luxation. as well as that retinal detachment, which could be due to traction by those intraocular membranes. There was also evidence of vitreal degeneration grossly. The vitreous was liquefied, so it could be secondary to that as well. So kind of a complicated case with a lot of things going on and some very interesting lesions.
Yeah, the corneal lesion is very interesting. I wonder
Yeah.
if it's the same thing that happens with xenoretinal endophthalmitis, where
Yeah.
probably started in the cornea with neovascularization and corneal stromal hemorrhage because of the lipid component of the systemic dyslipidemia. Then there's release, there's necrosis, and then the reaction kind of self-perpetuates and becomes the particle mass. So Kara is asking, what's the breed again?
This was a Havanese.
Havanese.
Yeah. Cool. All right. Well, I've cut into Dr. Shell's time substantially. Hand over to Bill.
Just need to stick you in that chair.
Okay.
No, so with my pants, you lovely. Let's take care of that. All right, now I'm gonna stick to this chair. All right. I guess we have time for this one. Okay, hello, this is Gillian. I have a case. This is an 18-year-old domestic long-haired cat, spayed female. We got the globe and a lymph node, which they said was the mandibular lymph node. And so the globe is a little bit collapsed, as you can see. But what we can make out is that there's a brown mass affecting the ciliary body, probably the iris, and it's also in the episclera right here, and perhaps going through the sclera at this point right here. There's also some brown stuff around the back of the eye, maybe in the episclera and other areas. So there's a brown tumor that's pretty extensive here. And then the lymph node, which has been hemisected, somebody took a lovely picture of it, has this area where there's a lot of brown stuff. So right off the bat, we have a monocytic tumor with concern for metastasis to the lymph node. So the globe is collapsed, so it's a bit distorted. Cornea is right here. Here's the iris on one side. Here's that area of the episclera that was all brown. And there's some increased melanin or brown stuff in the iris and ciliary body here, ciliary body over here. The retina is detached kind of artifactually, and there's some hemorrhage and or engorged vessels here. Lens is pretty unremarkable at this mag. So is the cornea. We did not sample the optic nerve in this section. I do have one more section or a couple more sections of the globe. So here is the cornea. Here's where you can see a more brown tumor that's bulging up into the conjunctival substantia propria. It's greatly expanding the ciliary body here, and it goes right through the sclera into the episclera. So, in the interest of time, I think I will just stay with this slide. So here's our cornea. So the neoplasm itself actually looks a whole lot more like a canine melanocytoma than your average feline iris melanoma. So when you get higher mag, the cells are kind of bland. They have nice prominent nucleoli, but they're relatively bland. Mitotic figures were not seen. We do have really extensive areas of necrosis, which also is very common in canine melanocytomas.
it seems like, and if you go to the lower mag again, the iris is not as affected. We've got great areas of the iris that are not affected. This is not a complete section. So anyway, and the more affected areas are the ciliary body, and then it extends right through the sclera into the episclera and into the choroid here. So this is choroid here. So this is what we call an atypical melanoma, because it does not share features with the vast majority of the feline diffuse iris melanomas. So in Coplow, we call this an atypical melanoma. Despite the bland cytologic features, these do metastasize, possibly at a higher rate than the normal iris melanomas. However, we haven't done the study or gotten the follow-up to really confirm that, but we do feel that these, I think, really kind of have a higher malignant potential, a metastatic potential than the feline diffuse iris melanomas, or the vast majority of those tumors. So let's move on to the lymph node. So the atypical melanoma typically will affect the ciliary body and choroid more than the iris. They often cause retinal detachment, which I didn't dwell on, but the retina was diffusely detached in the full section of the globe and very atrophied, so it had been detached for quite a while. So these folks, for good reason, did remove the mandibular lymph node that was enlarged. So from low mag, you can see that there are many lymphoid follicles with very large germinal centers. So this is consistent with at least lymphoid hyperplasia, but the more concerning part was that brown area that we saw grossly. And I think they actually sent us 2 lymph nodes. We only photographed one of them. So as we start to get higher mag here, we can start to pick up some brown. That's really more in the medullary sinuses. And when we go even higher, we see cells, large cells with brown stuff in their cytoplasm. Nope, that's as high as we can go. Okay, so I just want to point out that the melanin granules that are in the cytoplasm of these cells is very coarse. So you can see these are really relatively large blobs of melanin in these cells. And that's a pretty common feature. So the question is, are these metastatic neoplastic melanocytes that have exited the globe and moved into the lymphatic circulation, or are these melanin-laden macrophages? So, or could that be hemosiderin with another? So the first thing I did was an iron stain, and that stuff did not stain with the iron stain. So iron stain, this is a Prussian, we should stain them bright, any iron containing stuff bright blue. So you can see that those cells are not staining bright blue with the iron stain. As a positive internal control, if we zipped around a little bit, there are rare blue containing cells in the medullary sinuses, which I can't find under duress here. Did you see one?
Yeah, go back one few.
Oh, here. So here's a nice internal positive control. So this is probably a cell with some hemosiderin in it. So my next thought was, well, they still could be macrophages. How else can I identify a macrophage without doing IHC? And doing IHC on a macrophage with melanin in it is difficult. So I did a PAS stain, because melanin-laden macrophages, well, macrophages in general, especially that are phagocytically active, will often have PAS positive material in their cytoplasm. So here's my PAS stain of the lymph node. And I really felt, wow, it's even more dramatic under the camera than it is on the microscope, but I really felt that all these cells, all in quotation marks, had a lot of PAS positive stuff in their cytoplasm. So I was like, okay, this is probably good news, because my bias right now is that these are macrophages, that they're not melanocytes. But then I was like, well, maybe I should do a PAS on the globe to see how many of those cells. This is a great exercise, actually. So then I ordered a PAS. So 4 weeks later,
I finally have the final report in this case. After I ordered all of these special stains in sequential order and not all at once. Anyway, so here's our globe. I'm going to start right up here in that area where there were cells that were more lightly pigmented. And in this area, these neoplastic melanocytes typically do not, oh wow, it's really pink on the screen. I swear it's not as pink under the scope. So like some of them, like this one, does have some pink in it under the scope as well. But most of these cells don't really have very brightly PAS positive stuff under the microscope, at least, without being seen through the camera. There are definitely some cells around. So for example, right here, under the camera, this looks all bright pink. Under the camera though, there's some brownish tinge to these granules. So in my opinion, my low budget way of identifying macrophages kind of worked pretty well here. So honestly, I think what's in the lymph node is melanin-laden macrophages. And actually, when we look at this globe and out in the episclera, which I didn't dwell on before, but there's a whole lot of like free melanin out here. And then also when we look at the PAS, a lot of cells that have a lot of PAS positive material in them. So I think there's a lot of necrosis of these neoplastic cells and phagocytosis of free melanin by macrophages. So does this guarantee that this cat does not have metastatic disease? No, it definitely does not. But what I see in the lymph node does not look like neoplastic melanocytes to me.
Do you have a red chromogen CD204 for cats, or do you know if that works?
We can do red chromogens on most of those, yeah.
Yeah, I was skeptical that interpretation would be great. So I didn't recommend doing a CD2, or maybe I did. I can't actually remember what I recommended.
CD18, feline CD18 is still being worked up, so that would be an option as well.
Yeah.
And I've heard of PAS positive melanocytes. I had to look it up, and there's a 1999 paper that says this poster was discussed particularly because of the fact that melanocytes are PAS positive is not documented in the major textbooks of dermatopathology. This is important to remember because it may have implications for Dr. Shaw.
Okay, so the interpretation is that there's a paper from 1999 saying that melanocytes can be PAS positive. Did they specifically rule out macrophage possibility?
Yeah, it's a human thing, but yeah, this has come up before, and my answer is I don't know if they can be positive or not.
Like the location is more consistent with passive drainage.
Yeah,
absolutely. That's exactly where tumor cells drain.
Yeah.
Maria,
but they're just passively draining.
Maria mentioned here possibility that you might have a better luck with SOX10 since it's a nuclear marker with a red chromogen.
Yeah, we agree. We just don't have it.
Yeah, we don't have it.
We don't have it, and honestly, I don't know. I just don't think IHC is going to be very satisfactory here. So, anyway, so there we go. That's a nice example of what we call a feline atypical uveal melanoma. That looks almost identical to a canine benign melanocytoma, but does have metastatic potential. Someday we'll publish a paper about that.
And actually, in canine melanocytomas, we see a lot of PAS positive cells we interpret as macrophages.
Yeah. So that's all I have.
Cool.
Thanks, everyone.
Thank you.
Oh, I didn't go back to the PowerPoint. Here we
Before you
go.
leave, do you want to answer in writing?
I did not update this. I'm sorry. This is the old one before I did the PAS. So there we go. Thank you, everyone. Have a good Wednesday.
You guys in 2 weeks.